Welcome to the latest episode of Star Cells in God. My name is Fazale Rana. I'm a biochemist and a Christian apologist, and I'm joined via Zoom by Dr. Christina Cirucci, who is a board-certified obstetrician and gynecologist. And today we're going to be talking about the question, is gender reassignment surgery effective and safe? Chris, welcome to Star Cells in God.
Thanks for having me, Fuzz. It's great to be here again.
Yeah, well, it's always great to have you. In fact, I should probably have said welcome back because you've been on the show a number of times. There's some great episodes where you talked about the dangers of chemical abortions, abortion pill reversal, more pro-life topics. But you also have been on to talk about gender-affirming care, and specifically the dangers and the side effects of puberty blockers and cross-sex hormones. So if viewers and listeners want to catch up to those episodes, they can look through our show archives to find them. Those are great episodes. And Chris, I'm grateful that you're back here with us to continue the conversation about gender-affirming care, where today we're going to be looking at the question of gender reassignment surgeries. So again, thank you for being with us.
Oh, it's great to be here. Thanks for having me back.
Yeah, before we get into the topic, I think it's worth taking a quick second to ask that so what question. You know, why is this conversation important in your estimation?
Oh, well, that's a great question. It's a very important conversation. If you're conscious, you know that this is a big topic lately. And I think it's most important. The easiest way to say why it's important is because this involves people. People, especially young people, are struggling with gender dysphoria more than ever before. And so this is important to get this right, to give them the best care, give them evidence-based care, and to do the right thing to help them.
Yeah, I appreciate that. And, you know, at Reasons to Believe, you are part of a team that we affectionately refer to as the Gender Identity Team that has spent quite a bit of time and hard work going through the medical literature, looking at what does the evidence say about gender dysphoria, about gender-affirming care, you know, what is the etiology of gender dysphoria, not so much so that we can engage more effectively in culture wars as Christians, but rather, as you point out, because there are real people that are being impacted by gender identity issues that have to make critical decisions in terms of their medical care, in terms of what they're going to do. And we felt like it's really important for people to have the best information without any kind of real agenda shaping the conversation. And so you, again, are headed up that team and continue to head up that team. And so we're so grateful for your efforts. And I can tell you from some of the comments I've already seen coming into the ministry that your work is really impacting people in the way that we had hoped.
Well, that's good to hear. It's an important issue, and that was our desire, was to help people. And I like what you said. Our team went into this we all have our own biases and thoughts going into something, but we really went into it with the goal, what does the data say? Whether we like it or not, what does the data say? And because we, like everyone at Reasons to Believe, want to know the truth.
Yeah, thank you so much. Okay, so let's go ahead and get started with today's topic. And maybe the place to start first is, what is gender-affirming care? I'm sure people that are listeners and viewers have heard that term, heard that concept, but they may not be fully familiar with what is entailed in that particular description of treating people with gender dysphoria.
And that's a great place to start. So historically, if you go back 20, 30 more years ago, first of all, gender dysphoria was very rare, and it was in certain select populations in general. And for young people, the standard of care was what was called watchful waiting, meaning supportive care, psychotherapy, but not immediate transition, because multiple studies have borne out that the large majority of young people with time will become comfortable with their sex, with their birth sex. So that's this traditional form of care. And then recently we have what's called gender-affirming care, which means, as it says, the provider is obligated to affirm the young person in the gender they desire to be with a minimal evaluation. So if the young person says, if a girl says, I'm a boy, then the provider is to affirm that gender, and then send them on, and then they can be sent very quickly along a path of transition.
Yeah, and so you have a great visual that kind of shows the steps in gender affirming care, and maybe we could show that and to the audience and just talk through really what are the steps that are involved, because as you said, it seems as if in today's milieu, the intent is to get people into some mode of transitioning their gender as quickly as possible, even for really young children.
Right. And as that little graphic shows, there's we like to think of it as 4 steps, but I want to clarify that, every person is different. So some people may do some of these steps, but not all of them. So it's not all the same for everybody. But typically the first step is what's called social transition. So that would be taking on a name and a pronoun and wearing the hairstyle and clothing of the opposite gender, or whatever gender they desire to be. And then the next step, if someone has not gone through puberty, the next step would be puberty blockers. So that is a hormonal injection to halt the normal physiologic process of puberty. So a girl would not go through normal puberty for a girl, a boy would not go through normal puberty for a boy. And parents are often told, or we hear that they are told, oh, well, it's just buying time. It just gives them time to decide. But multiple studies have borne out that somewhere in the range of 96 to 98% of those who go on puberty blockers go on to cross-sex hormones. So it does kind of send them on that path. And then the cross-sex hormones are taking the hormones of the opposite sex. So a girl who desires to be a boy would take testosterone. She has halted the process of the estrogen in her own body to bring on the female secondary sex characteristics, and now will take testosterone. So she will get facial hair, deepened voice, etc. And a boy who wants to be a girl, if he's taken a puberty blocker, he blocks his own puberty, and then he takes estrogen, he will get, body fat in different areas, and more facial, more feminization of his features and such. So that's cross-sex hormones. Now, some people then go on to have the surgery, which used to be called gender reassignment surgery, which I would prefer now called gender-affirming surgery. And that would be surgery to make your body look like the opposite gender. So there's what's called top surgery or breast surgery. And then there's bottom surgery, which is the genital surgery. And then there are other surgeries like liposuction or shaving of the Adam's apple or facial reconstruction. And again, everybody's different. So some people have some of those and not all of it. But that's a summary of what we're talking about here.
Yeah. So the idea of the gender affirming surgery, to use the correct terminology, is in effect one of the last steps, and not everybody that is going through that transitioning process will necessarily elect to have that done, but it is, again, considered to be part of gender affirming care. So what are the requirements to get approval for surgery? Because as we'll find out in a minute, some of this surgery is pretty invasive and extensive and radical. And so it seems to me that particularly if you're dealing with a younger person, that everybody would be pretty circumspect about performing that surgery beforehand.
Yes, so requirements have changed. As I said years ago, a couple decades ago, or less. It was the watchful waiting in young people particularly. And now it's the gender affirming care. But even within gender affirming care, those requirements have changed. So the World Professional Association for Transgender Health is the organization that publishes the quote unquote guidelines that most organizations will follow. So the American Medical Association, the American Academy of Pediatrics, American Psychiatric Association, and most gender clinics. Now, I want to explain that other organizations, particularly American College of Pediatricians, Christian Medical and Dental Association, Catholic Medical Association, these organizations would not affirm WPATH's guidelines, but that is what is mostly being used. So we're going to look, if we look at the WPATH guidelines, it used to be that the person had to meet a certain age criteria. So they couldn't have gender surgery till they were the age of majority. And now there's no age limit. It's a stage approach. So in fact, we have a nice little chart on the slide that might be helpful here. So it used to be age approach, now it's stage. So in 2012, the WPATH guidelines said you couldn't have hormones or surgery till the age of majority. In the US, that would be 18. So now young people can have puberty blockers and hormones right at the start of puberty, and there's no lower age limit for surgery. It is recommended that they have that a young person have an adolescent have 12 months of hormones and an adult 6 months, but that's not required. They also, the guidelines also say they have to meet the criteria for gender dysphoria if needed to access treatment, which is interesting. I am assuming that means if your insurance requires you meet the diagnosis. The gender dysphoria has to be marked and sustained over time. So they have to be able to consent, which is another whole issue we could talk about, because now parental consent is no longer required. So now we're talking about a minor consenting for a major intervention, which is not typical in medicine.
So so let's dwell on that point for just a second, because I think that's really significant. And that is, if you have someone who's under 18 who needs some pretty significant surgery, before that surgery is performed, the standard is that the parents or a guardian has to consent to the surgery, even if you are in a life-threatening situation, right? But what you're saying here is that the parents have no really authority in, giving thumbs up or thumbs down to the procedure. It's up to the child to give consent. That seems to be a pretty radical shift and is contrary to what happens with other types of surgeries. Am I mistaken about that?
You're absolutely correct. I mean, I have a friend who's a school nurse. She can't give a Tylenol to a student without parental consent. We don't let kids drive till they're 16, vote till they're 18, drink till they're 21, and there's reasons for that. So, I mean, there's a couple issues here. You certainly don't want to exclude the parents. And I want to be clear that they say parental consent is desired or some wording like that. But if it's problematic, then it's not required. So you wouldn't just want to have a parents on board with something like this, but children, young people's brains are still forming. And in fact, there's a very good statement by the American College of Pediatricians about how they really do not have the cognitive maturity to be able to consent to some of this. And these are life-changing decisions that they may not be on their radar of what they're signing up for.
Yeah. All right. So sorry to interrupt you with that question.
That's great. So, right. So the guidelines have changed. There's not age limits. There's stage limits, stage guidelines. They're, supposed to be informed of the reproductive effects because many of these things make people sterile. They are to be given the opportunity to freeze their eggs or sperm, but most young people don't, a very small percentage do that, which is interesting, which kind of reinforces what I was saying. I don't really think on their radar. I think they're looking for a cure for their distress, and they may be told that this is going to help them. And so they want to just get rid of their distress and get some relief, thinking this is it. And we need to be very, very careful in proceeding along those lines.
Okay, so let's spend just a few minutes talking about the types of surgeries. You mentioned in very broad categories what those surgeries are, and we could probably spend 2 or 3 episodes unpacking the different procedures. But really, what I want to do is give viewers and listeners a sense of what is actually happening with these surgeries. So maybe if you could give us a quick summary of some of the different types of surgeries, and maybe just drill down into 1 or 2 of them. So again, people have the sense that of what we're talking about here in terms of the radical nature of these surgeries.
Sure. So let me talk about this first, female to what I'll say, female to male, a female that desires to look male, and then I'll talk about the other. So a female who desires to appear male, typically the most common surgery is going to be breast surgery. This is a double mastectomy with some reconstructive changes. So I will preface this, any surgery has risks. There's always a risk along with any surgery, and you have to weigh that against the benefits. So putting that aside, the common risk of any surgery, we have to realize when a 12-year-old or a 15-year-old has a double mastectomy, the major problem I see with this, they will never be able to breastfeed. That may not be on their radar. They will never be able to breastfeed. We often think of a double mastectomy in an older woman with breast cancer in which the benefits outweigh the risks. But now we're talking about a younger person having a mastectomy. And then let me finish with female to male. So then a woman who desires to appear male will probably have if she desires to proceed, a hysterectomy, removal of her uterus, and removal of her ovaries. Well, that's a surgery I do for other reasons all the time, and there's risks as with any surgery. But when you're doing it for gender reassignment in a young person, particularly, realize she will never be able to carry a child if her uterus is removed. If her ovaries are removed, so they produce estrogen. Now she's taken a hormone, the puberty blocker, to block that. But now if you remove them, they're permanently, she's permanently not going to be producing that level of estrogen. So we all know the jokes about menopausal women going through menopause at age 50, but now we're talking about a young person, 12, 14, 16, 18, going through basically menopause and not having the estrogen on board to protect their bones and their heart and, all those things. So then we get into the more invasive surgery. So again, a female wanting to be a male will have her vagina removed or closed off, and then construction often of a penis and testicles, prosthetic testicles. So the procedure is called either a phalloplasty or a metoidoplasty. A phalloplasty is constructing a penis-like structure that looks pretty much like the structure. A metoidoplasty is a less invasive procedure. But I don't know if you want me to get into this now and explain a little bit about what this is, because
yeah, why don't you go ahead and do that?
it's a complicated surgery. So to have a phalloplasty, so again, a structure that looks like a penis, tissue is taken from the forearm, a big piece of tissue, and then a cylinder made and reconstruction done. This surgery is a long surgery. It's detailed. It's fraught with complications. So one study showed like 76% of people had complications. Some of the major complications are urinary. So the urethra is the tube that goes from the bladder to the outside to empty the urine. And if men have a longer urethra than women, so somehow that needs to be created out of other tissue. And there can be complications where that gets closed off and the person can't urinate, or they form what's called a fistula, which is a connection to another organ, and that usually has to be fixed surgically. Now, these aren't complications that happen in like 1% of the time. These are happening 20-30% of the time. So they're pretty serious and significant complications. So that would be female to male. Now, if you talk about men who desire to look like women, they may have like I said, the shaving of the Adam's apple, the facial surgery, breast implants for the top surgery. But then we get into the bottom surgery for males. So then we're talking about removing the penis and the testicles, and then creating a vagina-like structure, which, this, I'm just going to give a warning. If somebody doesn't want to hear this, could be the time to turn the sound off. But the typical way this is done, it's called penile inversion vaginoplasty. So vaginoplasty means making vagina, and they're basically taking the tissue from the penis and inverting it. Now, if the person had puberty blockers, there's not enough tissue there. They never went through male puberty. And so they use the intestine. So they take a piece of the bowel and make a vagina. And then that has ongoing malodorous discharge. Often people have to do dilation for a period of time after construction of the vagina. These are not easy surgeries. Again, significant complications, often urinary, often the fistula, or the closing off of the urinary stream. So significant issues there on that. So that's kind of a summary of the surgeries.
Yeah, well, and they just sound gruesome. I mean, there's just no other way to say it. I mean, any kind of surgery has an element of being, a little bit horrifying to an uninitiated person. But this, again, these are surgeries that are being elected with, out of desperation to change, one's gender. But, you have to think about, what is the benefit of doing this if this is the type of cost that the patient incurs? And I mean, when you think about it, the whole idea of doing this kind of radical surgery to change one's gender is not something that you would necessarily think to be possible, at least at first glance. So where on earth did this idea even come from about really changing one's body in this radical of a way?
That's an important question. Where did this idea come from? And I think for any of us over 30, kind of keep asking ourselves, what happened? But it's a worldview change. In summary, it's a change that says your gender and your sex are two different things, and that your gender is what you feel and your sex is biology, and that there can be a disconnect. Now, in some people, they do feel like a different gender than their biology, but the solution, as we can talk about this more, but the solution is not to change the body. That doesn't actually benefit them. But it's the idea that your body and your mind are kind of separate and you're not one united person. It's seeing gender as a social construct rather than how God has made you.
Yeah. Okay. And then, how many of these surgeries are being done? Because it's one thing to talk about these surgeries. Is this something that's rarely done? Is this something that's growing in frequency?
Right. I don't know that we know exactly how many are being done. What we do know is that they are definitely growing in frequency. There was an article, and we have a graph we can put up. This is from JAMA Network Open last year, where they found that from 2015 to 2020, the surgeries had tripled. So if you see this graph, the lighter blue is the total number of surgeries, and that's increased. And the yellow is the breast surgery, the darker blue is the general surgery, and the gray is other surgery. So you can see that they're increasing. So from about just under 4,000 to about 13,000 in 2020. I would imagine.
And this is in the US, right?
Excuse me, this is in the US. We also see that the most common surgery is the breast surgery, followed by general surgery, followed by other surgeries. So as we talked about, not everybody has everything, but they're definitely increasing and becoming more common.
Yeah, and you know, again, not only are these surgeries gruesome, but I mean there are long-term consequences, right? The sterility is one of them for both the male to female and the female to male surgeries. And I would imagine there's lifelong complications too in terms of things like urinary tract infections and things like that. Am I correct about that?
Long-term urinary complications, and yes, and this isn't something this is a permanent change. This isn't, you can't go back to what you had before because you're removing and changing your body parts. And in medicine, I mentioned this before, you wouldn't, the benefits have to outweigh the risks. There's risk to anything, and taking a medicine has risk. So, but the benefits have to outweigh the risks. So if somebody goes through chemotherapy, there's a lot of risk to that, and it's not very fun, but they're concluding that, and the doctor's concluding that the benefits are worth it. So that's the question, are the benefits worth it here? So I don't know if we can get into that about.
Well, I mean, let's do that, because oftentimes what we hear is that unless you allow a young person to go through gender-affirming care, that the likelihood of them committing suicide is really high. And so it's almost like this emotional justification for allowing a young person to go through this kind of procedure, accelerating this as opposed to watching and waiting, before something like this is done.
Right. And that's often what we hear, a parent being told, well, do you want a dead daughter or a living son? Well, what's a parent to do with that? So that is the idea that, well, if you don't allow them to transition, they will kill themselves. So first we have to understand that unfortunately people that suffer from gender dysphoria are at higher risk for suicide. They do have higher mental health disorders and afflictions. They do have there's higher incidence of autism, of sexual abuse, of bullying. And I think the appropriate thing is to address those issues, not to say, well, this will fix it, because what's been shown is that it doesn't. So let's look at the suicide issue. Do you want a dead daughter or a live son? So, well, let me say first, one of the things we found on our team was that we don't, and this is echoed by many other organizations, we don't have good data on this. So there's plenty of studies, but the quality of the studies, and this isn't meaning the researcher did a bad job, it just means the design of the study, the follow-up, how sure are we that these studies really reflect the results they seem to reflect, is low quality. So we don't have good studies, but one of the few good studies we have, a long-term study, was a trial. It was in adults where they followed them long-term. So one of the few long-term studies, they looked at people that underwent gender reassignment surgery, and they compared them to controls, not just controls of their birth sex, but controls of the sex they were transitioning to. So 10 of each. So each person was compared to 20 controls. And over time, they found those who had underwent sex reassignment surgery had 19 times the risk of suicide. So if anything, our data shows the opposite, that this isn't reducing suicide, but it could be increasing it.
Yeah. Now, are there any benefits that all for this type of surgery? I mean, do people feel glad that they had the surgery initially, even though they may still suffer from depression and suicidal tendencies, later on?
Yes, sure. That's a good question. And so again, everybody's different. So sure, there are some people that probably have this surgery and are glad they did and feel relief or whatever. And in some people, that feeling is more so early on, and as time goes on, they regret it. But if you go back and look at the initial studies, and we talked about this before, the Dutch protocol.
Right.
So those were two studies in 2011 and 2014. So in 2011, they took 70 young people and evaluated them, but they gave them puberty blockers. This is where the puberty blockers all came from, and then cross-sex hormones. And they evaluated their functioning. And in some measures, they were improved. And in some, like gender dysphoria, wasn't improved. So it was kind of a little bit of both. But these people also got psychotherapy.
Mm.
And there was no placebo group. So we don't know. We don't know, first of all, what would have happened if they had nothing done. And we don't know what would have happened. We don't know what would have happened with the psychotherapy alone, which treatment helped. Then they did another study where they followed these people over a longer period of time, the same 70, only they excluded 15. So 15 people were excluded. Some didn't. They looked at them in this second study after the surgery, or a year or more after the gender reassignment surgery. 15 were excluded, some because they weren't medically okay to have surgery, some because they didn't follow up. And one person died of the surgery, that they excluded them from the trial. And again, they showed that these young people, after the surgery, their functioning was similar to that of their peers. And so this is touted as beneficial. But again, well, first of all, what would have happened if they did nothing? Because I don't know about you, but I was much more comfortable and adjusted at 23 than at 13. So, what would have happened if they had nothing? Plus, they also got psychotherapy. Now, if these trials were just kind of the start of other trials and we have better trials, but the results of these have never been replicated. And the people in these trials are different than the people today, different things. So we don't have data that clearly proves that there's any benefit. There was another study by Brandstrom and all others that looked at mental health. And they concluded that for each year after sex reassignment surgery, the mental health usage of resources dropped by 8%. Well, after this study came out, people started writing letters because they realized that the statistics weren't right. And so they redid them, and then they found there wasn't any benefit. So again, there's good studies and bad studies in a lot of areas of medicine, but what we don't have those long-term randomized controlled trials. We don't have good data that says this is beneficial. And so one of the principles in medicine is first do no harm. I can't always help people. I want to help people. I can't always help them, but if I can't help them, I'm not going to throw something at them that I don't know if it's going to help them or hurt them. So this is the problem we're dealing with here. We are dealing with people that are really struggling and they need help. Transition isn't the answer, unfortunately.
Yeah, particularly when you're talking about this kind of radical gender-affirming care, whether it's puberty blockers, cross-sex hormones, or something as radical as gender reassignment surgery. Now, there's been some recent news from the American Society of Plastic Surgeons about gender-affirming care. So could you tell us what's going on there?
Yeah. Interestingly, this came out in the summer. So American Society of Plastic Surgeons, obviously they're doing a lot of these, would be the ones doing fair amount of these surgeries. So as I mentioned earlier, a lot of the medical organizations affirm the WPATH guidelines, but the American Society of Plastic Surgeons came forward. They didn't reject anything, but they said, we do not endorse any guidelines on gender care for adolescents. And their reasoning was that they needed better data. And so I think that's, this has happened a lot in other countries, but now we're starting to see it in the US.
That's good. And so what is happening in other countries? Because I think if anybody's paying any attention to the news, we understand that here in the US, we are becoming increasingly outliers in terms of advocating for gender affirming care,
Right.
when in other countries, the perception I have is that people are putting the brakes on these kind of treatments, particularly for young people.
Yes. So it's interesting because this all started in Europe. Like I said, the Dutch study, so that's Netherlands, and a lot of these studies were done in Sweden and other Scandinavian countries, etc. And we see these countries pulling back. So in many countries in Europe, the surgery's banned before age 18. Sweden, Finland, and the United Kingdom each independently did systematic reviews on this study and said there's not enough evidence for just even for hormones in young people. So in many of these countries, it's banned before age 18. Some of them will allow a mastectomy at 16, but we're talking Belgium, Finland, Germany, Luxembourg, Netherlands, Sweden, United Kingdom. So it's interesting. We often think of Europe being kind of doing things before the US in this kind of area, and they did, and now they pulled back because they don't see the evidence.
So do you think that what we are seeing with the American Society of Plastic Surgeons is a harbinger of what is going to happen in the US? Or, or do you think otherwise? Maybe another way to ask the question is, why is the US so far behind the curve when these other countries in the Western world that have comparable medical care and sophistication of medical care as the US are
Right.
reaching very different conclusions about gender affirming care?
I don't have that answer. I mean, it's the US, it's Canada. You would hope that the plastic surgeon statement is a harbinger. There are many organizations speaking out against the lack of data, against the harms, but we're still seeing it. We're still seeing, physicians feeling like if they don't do this, they're going to lose their job, et cetera, et cetera. We see this in other areas in culture here. But we also see young people who are detransitioning and then are speaking out. Or we see whistleblowers like Jamie Reed at the hospital in St. Louis, who, she's like married to a transgender person or whatever, but she saw the harm that was being done and she spoke out. And so we see people speaking up. Chloe Cole, a young girl who had a mastectomy and now realizes, well, I just needed help for my struggle. I didn't need this. And so it's unfortunate that people have to be harmed in the process. But I hope that the truth can come out.
Yeah. As we kind of bring this conversation to a close, Chris, what would you say to a young person or to a parent of a young person who is suffering with gender dysphoria, struggling with their identity, their gender identity? What would you say to them, first of all, as a physician? And I want to be careful here, because even though we're talking about medical issues, we're not giving medical advice on this show. People need to consult with their physician to get medical advice. But you are a physician and you've invested a lot of effort in studying, these issues. So what would you say, at least in terms of just general counsel, to somebody this is a reality that's in front of them?
So first of all, I would just say I feel bad that you're struggling with this. These are really difficult struggles. This is tough. And kids today are going through so much, and there's a fair number going through this gender issue. And so first of all, I would just want to express my empathy for their situation. And I think the second thing I would say is to take time, get information, especially to parents. Don't, just go to the first thing that's offered, read about this, learn about this. I would direct people to American College of Pediatricians has a website, Biologic Integrity, with lots of information. Miriam Grossman's book, Lost in Translation. We have our white papers are out that, so get information. I mean, these kids need help. They need, we've heard stories of girls who've been sexually abused and then want to become a boy so they won't be sexually abused. Well, we need to address what's going on. And these are not easy things. This isn't something we can fix with a couple appointments or puberty blockers or surgeries. But, I would just encourage people to take the long approach, take the slow road, get the information, and find, some good people that can give you the right kind of help.
Yeah. And, what would you say to somebody, again, where gender dysphoria is a real issue in their lives? What would you say to them as not a physician now, but as someone who's a Christian?
Yeah, it's hard to, because I don't know exactly that person. I always think the first thing I like to do with somebody is just talk to them and get to know them. I know somebody like this, and I just try to spend time with them and talk to them, and we're all people. And so we're made in the image of God, and we cannot change our sex or gender. That doesn't mean the discomfort isn't real. So, I would just encourage them to, if it's somebody I know personally, I would just want to walk beside them in this difficult journey.
Yeah. Yeah. Well, and this idea of the image of God is so important because it means that, people need to be afforded dignity and respect, right? And your idea of getting to know them and really developing that deep sense of care and compassion and love towards them is really critical. But, it's unfortunate to me that oftentimes, and we all really fall prey to this, is that we seek our identity or seek to define ourselves so often apart from the image of God. Whether it's what do we do for our career, what are our interests, what sports teams that we root for, we seek our identity in so many places as opposed to really in our relationship with God because we bear God's image. And I think when it comes to this issue of gender identity, that's very much happening as well, is that people tend to define themselves by their gender as opposed to by the fact that they are the object of God's love. Would you comment on that? And I'll give you the last word there, Chris.
Yeah, that's true. And I would say they define themselves not so much by their gender, but by the gender they identify with, and that can be changed, et cetera. But that's, we kind of talked about that. But yes, I think we see this, we all do it. Like, I'm a physician. It's easy to say, that's who I am, or you're a biochemist, you're the CEO of Reasons to Believe. And it's good to be productive and all that. But no matter where we are in life, those things, nothing else will give us satisfaction except God. It's just sometimes we don't see it as clearly, when we in certain situations. But yeah, we all need to find our identity in God, not in our productiveness or accomplishments or anything else.
Yeah. Yeah.
So,
Well, Chris, thank you so much for taking the time to be with us. This is a very difficult conversation, and I so much appreciate all the effort that you've put into really going into the literature and understanding the ins and outs of gender affirming care, and really the boldness that you show in terms of speaking out as to what really does the data show. So again, you're a treasure. I hope people appreciate that. So thank you so much.
thank you so much. It's just great to be here. I appreciate your having me.
Well, thank you so much for joining us today on Star Cells and God. We would really love to hear your thoughts. So join the conversation in the comments section below. And remember to like this video and to subscribe for more content. New episodes of Star Cells and God release each Wednesday and are available here on YouTube and your favorite podcast app. Be sure to share this video with a friend, and remember, the more we know about science, the more we have reasons to believe.